Okay, as we are just getting started here, I'd like to welcome everybody. Hi, I'm Robin Shapiro, Advocacy Association, or WASHA. It's so wonderful to see so many people joining us today. We're expecting about 50 people, and thanks so much for joining us for our second community conversation, this one focused on caregiving and assisted living. I'm delighted to welcome two wonderful speakers today, Dale Reisner and Albert Munanga. And we'll get going with them in a moment. But as people are arriving, I'd like to remind people that this is a community conversation that we are recording. And so if you do not want your video to be recorded, we will be making this available to the public. So if you do not want yourself on the recording, please turn off your video, and everybody should be on mute. A few housekeeping items. The chat function is how you will be able to ask questions. So if you want to test that out, pull up your chat window, which is at the bottom of your screen. It's the sixth icon over from the left. And last community conversation, we had an unwanted visitor, and if that happens, just rest assured we'll be able to remove those folks. So let's get started. Welcome to the WASHA community conversation on health advocacy in the age of COVID-19. We are so lucky to have two experts today, Dale Reisner, who is a doctor and is the medical director of OBGYN quality and safety at Swedish Health Services. She'll be leading off our call today. We'll be followed by Albert Munanga, who is a nurse and the regional director of health and wellness at ERA Living, and is also an affiliate faculty at University of Washington Department of Biobehavioral Nursing and Health Informatics. And you'll see both of them in a moment. Dale will start us off with basically news and information, changing information on COVID and what's happening in our community. And I'd like to hand it over to Dale. And feel free, if you would like, to ask questions in the chat function as we are going. So with that, Dale, take it away.
Okay. Well, good morning, everyone. It's a pleasure to be able to lead this discussion off a little bit about where we're at in Washington State with our response to COVID and our current situation. So we have, obviously we were the first identified state to have COVID positive patient. And then mostly due to lack of testing, we've been pretty much behind the eight ball as the rest of the country is by being able to manage this this novel virus, so it's a new virus, in the way we would typically from a public health perspective, which is identifying contacts and testing them all and isolating just the people who are positive. So we know that there are a lot of people in the community that are positive. We have learned a lot about this virus, that it can be asymptomatic completely. So having the virus and having nothing that feels different to you. It can have mild symptoms that feel or sound like a common cold. And actually it's a coronavirus, and the common cold is in the coronavirus family. It can be devastatingly impactful on your health, but have you survive? And there are people who do not. And we've seen this, it's all in the news. So I know that's not new to you. We're still missing a lot of information. We feel that it probably is, in terms of the infectivity, it's quite infective if you are close to someone who has it. So that is why the public distancing is so important, that you stay 6 feet away from people, and that the newer recommendation for universal masking is an important thing to talk about. So if you were on the call last week, I said, you know, homemade masks really don't do that much good, and that we're really needing all of the personal protective equipment for hospitals, and that is still true. The reason we would start masking now is the information that we have about probably 20%, 25% of those who catch the virus, who actually get that virus and get infected, are asymptomatic. So looking at lovely Robin, who looks like she's totally healthy, she may have coronavirus. And she doesn't know, and I don't know. And because we just don't have ample testing, she can't just walk in with no symptoms and ask for a test. And that's appropriate right now. Eventually, when we get broader ability to test asymptomatic people, we'll have a much better sense of where we need to go with continuing the shutdowns of the schools and the non-essential businesses and all of those things. So the benefit of masking yourself when you go out in public is not that we think that's going to protect you as much as hand washing and staying away from others. But if somebody who is infected does not mask, then you at least are keeping any of that away from your mouth and face. So it's the same recommendations. Keep your hands away from your face if you can. And one of the things that's a little concerning about universal masking is that, you know, you're putting your hands on your face to put the mask on and take it off. And so there's actually maybe more potential if your hands are contaminated to get them on your face. So just be cautious about that.
So does that mean, Dale, can I ask you, Dale, does that mean that whenever you mask, maybe washing right before you put the mask on and then as you take it off?
Yep.
Yeah.
Exactly. So that is what we do in healthcare. We mask before we wash or use hand gel before we put gloves on. We wash or use hand gel when we take gloves off. We do the same with our masks. And we don't necessarily do the same with our masks when we're not in a pandemic, but we're learning that maybe we should be more meticulous about that in general. I think there will be a lot of good lessons coming out of this, and I don't think that we will ever be quite as casual about how we act in public. I'm hoping that we will be more mindful, but just encourage you when you go to the store, if you have gloves that you can, you know, when you're handling things, that's great to put those on. When you come back out, if they're washable, wash them, or if they're the rubbery ones, spray them with your gel stuff or, you know, the alcohol solution, and wear masks when you're in public. It is respectful for others. Even though it may have minimal protection for you. The homemade masks are fine for use there. We definitely want the official masks to go to the healthcare providers that are on the front line. I did want to also just update you that we've been tracking, not only in the Swedish system, but in all of Washington State, where we are with this pandemic. And we were doubling our number of cases, initially every 3 days, and then it spaced out to every 5. And now what we have, looking at the Swedish system, which is Cherry Hill Hospital that specializes in cardiac and neuro care, Issaquah, Edmonds, Ballard, and First Hill. So it's a lot of people that we're seeing in our system. It's doubling about every 7 days. And we really think this is from social distancing and from people using, their own hand and washing precautions. So the other thing is we were expecting that our peak use of personal protective equipment and patients in through the hospital and beds, ventilators, all of that was going to happen in this week or the next week. And it looks like it actually peaked last week. So that doesn't mean we're done. Yeah. Our highest days were last week. Now we could have another spike and we're definitely not done. But if you look at the predictions for the whole country, what we see is a little bit of a decline in each state's rate of the highest amount of use. So the most patients that come to the hospital, the sickest patients, and we will still have deaths. So our peak death rate in Washington State is what we heard before, still over 600, and it's aimed right now probably to happen around the end of April. So when you hear me say our peak use is probably past, that's awesome, but we are not out of danger in any way. So I just want that to be super, super clear. Getting back to what was normal is not going to happen. Getting back to closer to normal is going to take some time. And Washington State is really not that far in terms of our infrastructure and the governor's safety measures that have been put into place, that when it's the right time, we can start rolling back a little bit. But it's not going to be, by June, we're going to have, 500 member meetings in person. That will not happen. And just if you're interested in vaccinations, there's a lot of work and effort. I know Bill Gates is putting a bucket of money into vaccinations, into creating vaccinations. And those, however, to be done properly, tested properly, will not probably be available till the end of the year, if that. So don't be thinking that you're going to get vaccinated, in September. It's really unlikely that we would have anything by that time, unless the Chinese researchers have, who jumped on it a little bit quicker may have something. But that's the anticipation for that. So we're still going to have to be careful for quite a while.
Mm-hmm.
I think that the one other thing I just wanted to say is that we still need blood donations. So if you are healthy and can donate blood, they are taking appointments. We had a huge community response to the initial requests. And I think things have stabilized a little bit, but we're still behind. And so if you're looking for something to do as a community member, that's still a really great thing to do. And you can go on to either American Red Cross or Bloodworks Northwest to look at how to schedule an appointment for that. So I'm going to stop with that.
That's a great, great reminder on the blood donation. Thank you. And we did have one question come in from Margaret Monseroff. Is there any chance that there will be a test for immunity sooner than a vaccine?
Yes, but don't ask me when. Yeah.
So, and do you want to describe what that means for people that might not understand that?
Sure. Mm-hmm. Happy to do that. Yes. So if you get any infection, your body produces antibodies to fight off that infection. And the first antibodies we make are called IgM. So those are usually present. They're present first in the course of an illness when our body starts revving up to fight it off. And they last for, depending on the virus or the infection, they last for weeks to maybe a few months afterwards. Mm-hmm. After the IgM, which is the first responder in our immune system, is generated, we start making IgG. And IgG, these are gamma globulins, so they are our own internal protective mechanisms to fight infection. And that particular antibody can last for a year, years, or a lifetime, depending on the virus or the type of infection. Mm-hmm. So the common cold, for instance, we can make antibodies against the common cold. They come and go really fast, those antibodies, and that's why we get the newest version all the time. But something like, the wild virus, the virus that's out in the community for chickenpox, for instance, we will make antibodies against chickenpox that will last a lifetime. And so there are the types of viruses that we've known for decades. If we were exposed to those, whether we looked infected or not, we will have circulating antibodies against that. That for many of these illnesses will take a long time. Yeah.
So yeah.
available now, but it's not available for the public. So people can test that. They know that they can identify that, and we will hear more about that. And I think that will be part of our getting back into circulation will be those who, first of all, who had the disease or were around someone who had the disease, making sure that those folks are protected. And then potentially, and especially in small settings where we're not having huge numbers of employees, we might be able to get some of these smaller businesses back to work sooner.
Great.
But
So,
not
yeah.
probably a couple months. Yeah.
Yeah. Thank you. Thank you. So, so this is very helpful. We're getting a lot more questions, obviously, but I really want to now go to Albert Munanga. And let me just find where you are. So Albert we're so grateful. We know both Dr. Reisner and Albert, you are super, super busy on the front line. So we really appreciate your time and attention. Albert's going to talk a little bit about what the assisted living communities are seeing and what measures are being taken to protect people and also, you know, what caregivers can be expecting both now and in the near future. So Albert, if you can jump on here, that would be great. I'm going to mute you for a moment, Dale.
Perfect.
Thanks, Robin, and thanks everybody. Thanks to Washa for just putting this together so that we can all come together and just have a dialogue about what's happening to our community. So I do appreciate the opportunity, and thanks Dale for really sharing very good information there. You know, for us in the retirement assisted living industry, we, like everybody else, we are watching the news of, you know, COVID-19 in China, and then we started in Washington State. One thing we did not envision was that we will soon become quarantine centers ourselves. That's the biggest thing I wanted to just hint on here, because it changes everything. Suddenly, I'll tell you my own experience. The first case we had, the hospital system and just the community reaction was strong. The individual was taken to the hospital very quickly. But within a short time, the hospital started saying, hold on, you can't just bring everybody that tested positive. And so before we knew it, it's happening across the industry where they are saying, if they are not very sick, if they are not, you know, showing respiratory distress symptoms, keep them in your community. So what that did, it changed everything very, very quickly. We had to reorganize ourselves, and not just from a pure infection control, clinical infection control processes, but how we just live every day in assisted living. All the mechanical processes had to be re-examined. Who does laundry? Who goes to that apartment with a COVID-19 positive resident? How do you take laundry from that apartment to the common laundry area? Who cleans before and after? And so you can imagine everything had to change and be re-examined. And so, but I have to say that I'm very proud of the assisted living community in general, because one thing that has been amazing to me is the level of transparency. We've been sharing information. If a community has a case, for example, at Era Living, we've been putting out memos on a daily basis. If we have a case in the community, we are letting every resident know, even if it's a staff member. We will let everybody know, and we will go back to the visitor guest log and call the vendors, call the guests, the visitors, oxygen delivery company. Hey, you came into this community at a time when we didn't know we had somebody who was, you know, active with COVID-19. So please, you know, isolate yourself and check yourself and make sure you're fine, and stay out from other people. So we've been doing a lot of these things, and it's humbling to see how the community has really kind of come together to make sure we share relevant, pertinent information across the board. But again, going back to hospitals, it's been interesting to see that we had to deal with the potential, well, not potential, but I should say that assisted living communities, we typically don't stockpile a lot of PPEs. We have tons of gloves. We may have a few gowns and very few limited gowns and face shields, just in case somebody has to be in contact or droplet precautions, right? But it doesn't happen that often. And so we had to deal with a big need, quite sharp need very quickly. And I gotta tell you again, there were communities that would call and say, we can offer some help. We had King County Public Health. I have to give them a big appreciation here, because they dropped a big shipment immediately at one of our communities, and that went a long way and bought us time to be able to safely care for the residents that had COVID in our community. Of course, we try to order like everybody else, and I will tell you that has not been very easy, because the delivery of PPEs it slowed down immediately, and it was sporadic, a few things here, a few things there. But I think the industry has responded well in general. One other example I can give you is that in our communities, we decided to go to cluster care, where we assigned specific staff to care for those that are ill with COVID-19. What that did, two things. Number one, it at least made us know who is making daily contact with those residents. And so the risk of exposure to many other people, like housekeeping, food service folks, was limited. So we had caregivers retrained to almost universal caregivers. So they went in to do almost everything that there is to do to help those residents. And so that helped us to also focus on this smaller group of people, to train them higher, to increase their confidence and their competence. But it also helped preserve PPEs, because you didn't have so many people needing to gown up and put face shields and do all of those things going into those apartments. So those are just some of the examples. Very quickly, I don't want to go on here. Another area is of course, we have residents in isolation, right? Following the social distancing order. There are no guests, families are not coming in, and families have been gracious. They have complied, they're not coming in. Most unnecessary, not unnecessary, unessential guests. We've seen like a huge cut in those visits, so which is wonderful, but of course it's created another problem. We have residents in isolation, just staring at the walls for the most part. And so communities, when weather permits, that have nice gardens, residents can get out and walk around and get back to their apartments. Of course, we're encouraging social distancing, and they are complying and they're understanding. Last week, we started deploying a use of iPads with Zoom, such as this, to connect our residents with their loved ones at home, to be able to connect, and in some cases, to also get them speak to their physicians or counselors. Our communities are fortunate to have social workers and counselors. So we have them in every community, and they're providing that support as needed and where it's needed most. I know that.
So, and you're prioritizing. My understanding from our discussion, we had a pre-discussion yesterday, is that because you're not having a lot of people from the outside come in, the highest residents with the highest needs are getting additional support in some ways, is my understanding.
Yeah, correct. I think this changes the ballgame completely, because our counselors now have to triage who needs their attention the most, who needs support the most. We have residents that may not have family that is capable of checking on them frequently. Some of the residents, their children are healthcare workers that have no time, extra time. It's like a quick call. Hey, mom, how are you doing? Mom, I gotta go. they need a good quality conversation. So we don't want
Yeah.
them, we don't want to forget about them.
So we have a few questions actually that came in prior to our call even starting, which was, should assisted living communities be accepting new residents right now? And especially if they have tested positive either in the community, or how is that working in assisted living communities? Like, are new people coming in? How are you accepting people who may have tested positive? How does all that work at the moment?
Good question. So I know that for sure, if somebody is outside of an assisted living community and they've tested positive,
Mhm.
we are saying, please don't come in. And I know that COVID-19 has not completely changed the law and the rights of individuals. So we're respectful of that. And people are wonderful. They're listening and they're understanding. So far, from myself or my peers, we haven't heard people insisting, no, I just gotta come in. And so I think that so far has been going well.
Mhm.
Then let's flip the situation. If a resident living at home is well, but wants to move into a community, and we have no COVID-19, we are still discouraging residents, because just moving involves a number of people. It involves movers, it involves just a lot of things to happen. And it also involves additional deliveries from pharmacies and other people. So we're asking that they stay home, but there were situations in the beginning when folks have sold their homes, they are ready to move. We had to plan it and execute it carefully with supervision. We had to designate an elevator. We had to provide supervision. We had to wipe the handrails as people walked after that. And then they had to stay locked in for 14 days before we would have them come out.
Mhm.
Very new world, right? New world order right now. And so, but if a community has positive cases, I would say, please don't come in. And again, we're not speaking in absolute terms to tell people as if it's the law of the land, but we are asking people not to. And so far, what I would tell you is that it's not been a problem at all. Most people, of
Mhm.
course, have stopped touring. Nobody wants to move in when you don't know how your new home will look like. And
Yeah.
so a lot of move-ins have really significantly slowed down, just like move out have significantly slowed down.
Mhm. So I have another question that came up a little earlier, and this is both for you, Albert, as well as Dale. And it says, from whom should caregivers plan to ask for tangible support if they become physically unable to care for their care receiver because of COVID-19? Family? Is there respite stay at assisted living or adult family homes? Is there in-home care agency? Are there options for help feasible or safe right now? Like, what do people do if they can't caregive? Anybody want to take that? Anybody have any ideas?
So I can go first, if you don't mind. So we're
Mhm.
looking at a caregiver not able to provide care, right?
Mhm.
Um, so the first thing we do, if a caregiver is sick in that specific situation, we're asking them to stay home. And we are checking with caregivers that are home. We have a few that are staying home, they're sick. Fortunately, most of them have recovered quickly and they're doing well. We are having them still stay home for for an extended period of time and get retested if testing is available. That's been a big challenge because some people are still testing, and Dr. Reisner may speak to this more, but a lot of people, depending on when their last symptoms resolved, they may still test positive for an extended period of time. So that's been a challenge because initially our reaction was that, hey, go get tested before you come back. Now it's like some people have gone two times, 14
Mhm.
days. past symptoms, and they're still testing positive, but they have no symptoms. In some cases, folks have tested negative and been able to come back. So, Dale, do you want to speak to that a little bit?
Yeah, as I started with the testing thing, it's still an issue. It's better than it was. We're about to get rapid testing. It's actually in the state. And we'll have to figure out who actually uses that, where's the best place to use that. It's about a 15-minute turnaround time. And but it won't be the one we do for test of cure, because we have time to figure that one out for test of cure. I think
so what do you mean test of cure?
Well, what I'm talking about, when someone who's been sick,
mm-hmm.
we know that they've been sick, excuse me, and they're my allergies, and so we know that they were COVID positive, and we want to be able to let them come back to work. Because of the unclear length of symptoms, we're going to be wanting to test those people and get
mm-hmm.
a negative test. So caregivers
mm-hmm.
are a priority for that. And I think that will be more available.
Mm-hmm.
Right.
Yeah.
And Robin, I want to tell you that I tried to order the 15 minutes test, the one that came out through
mm-hmm.
Medline.
Mm-hmm.
I was told on Friday that the priority is that those testing first have to go to the hospitals.
Yeah.
Yeah.
And so we have no clue in the retirement industry when we'll be able to have access to that. But we did order because it's faster and we'll be able to test more people more quickly. Because that's really the key. Once, imagine this, if a caregiver who is asymptomatic is capable of passing on the virus, and they're caring for 10 people,
Mm-hmm.
and they're being around other caregivers, and I mean, specifically the senior industry, one of the most vulnerable populations, that is what is keeping us at night,
mm-hmm.
is being able to know and not wait, because by the time we know, we may not have a lot of fatalities among staff because they are younger and healthier. But can you imagine a situation where we don't know, we are passing it on for a while, for weeks, and we have half a community? Our average community has close to 200 residents. Some have 360 residents. Can you imagine if half of that population has the virus? You're going to see a lot of fatalities in that population, like we saw in the skilled nursing facility, which is very unfortunate.
Yeah.
Yeah. So we're desperate for testing. This is why we're begging from physicians every time we get an opportunity. And we're not going by, I must say this, we're not going just by the CDC recommended guidelines, because I'll tell you, almost like under oath right now, that most of our residents that have tested positive had no respiratory symptoms. I'll tell you that 99% of them, they had maybe one episode of diarrhea, or they tell you that 2 days ago I threw up, and then you decide, well, this is one of those things we're looking for. So they're getting sicker a little bit later after all the symptoms manifested themselves in the last few days. The other bigger one is ordered mental status. When we see they're somewhat disoriented, they know themselves. I mean, a gentleman walking around with his pants not zipped up, kind of out of character, odd behaviors like that. And so those appearance of confusion have been big telltale signs for us. And we added looking for redness of eyes. We added folks that have not just reporting change in taste, but they seem like they've lost their appetite. They're not eating as much. So we're really casting our net a bit wider here, because we want to know ahead of time. But of course, like they said, testing is still a challenge, and we wish it wasn't, because if it was, if it was available, it would be fun.
Right. So a person re-asked the question. So and I don't know if we have an answer, so throw it out there again. But the concern is at-home family caregivers who provide 100% of the care for their loved one and have no support. If they get sick themselves, what is the best option? Are there any options for support out there that we know of?
Oh yes, oh yes. I think I know my wife is a clinical case manager for in-home care company, and they've been getting a lot of calls for that reason.
Yeah.
Yeah, but the flip side of that is that some families, because they're staying home, they have released those caregivers helping for their loved ones that are coming from outside because they are afraid they'll bring the bag to their loved ones. So there's been a lot of change in dynamics here. But yeah, the short answer, I know, apart from family and friends, right? For the professional care, it'll be in-home care that is a good option for caregivers.
Thank you. Thank you. We also had another.
I'll just add that.
Yeah, go ahead.
The person who, it's challenging because it's interesting in this different settings, who is testing more widely and who is not. So the University of Washington has their own in-house testing is doing of all of their OB patients. We cannot do that at Swedish. So the same thing that Albert says in his patient population, in his residents, because they're high risk, there's more of an inclination to test and screen them. But we don't necessarily have that for every single residential care site either. So I think that the caregiver who's at home and can't find someone to replace them who's sick needs to spend the least amount of time with their family member, needs to wear a mask when they're around them, wash their hands, wear gloves, if they can grab a shirt that they are going to treat as a, kind of a protective thing over their clothing, just when they go in that room, they can do that. And then they can prepare the meals or, at least be there for emergencies for their loved one if their loved one cannot be left alone and they can't get a replacement. They, people don't necessarily automatically spread it if they're careful, and if they can keep their distance most of the time, be super careful when they have to have contact.
So I think Shawn D'Amelio, are you? There we go. Yeah. Hi.
So yeah, it's been really challenging from the home care side of things because home care typically does not have PPE. We don't use PPE with the exception of gloves. So we're not on any list to get PPE, although we're working hard to do that and to try to be, we're considered essential in the care setting. However, we aren't on the list to receive any PPE, even if it's sent from the government. We're not on that list. So that's some of the challenges we're facing. One of the things that I jokingly but non-jokingly said, if somebody's leaving the hospital, they should request from their doctor as they're leaving, can I take a mask for myself and my caregiver? It's a possibility. It's a small possibility that they'll give it to you, but it is helpful if you can get it yourself. And while we're trying to do kind of a mass purchase of PPE for home care, we haven't actually been successful at doing so. The other thing is, kind of remembering to do if you are home caring for somebody that is, if you have it and you're caring for somebody else, you're going to practice those same 6-foot distancing. One of our caregivers said she's using a 6-foot ribbon and laying it between so that the person she's caring for is kind of getting, this is how far I have to be from you. So there's a real visual for somebody, especially if they have any kind of memory loss. I thought that was a good idea. But, and also really thinking about what is essential that I have to do that touches this person. Can they go without a shower? Can I
Yeah.
put a bath basin there for them and let them do their own thing? And it may not be what we normally would want it to be, right? But what can we get by with?
Great.
Is what I would suggest is like, you know, what do you actually have to do to touch them?
Yeah. And I am also just unmuted Vanessa Laughlin at Bannister Advisors, who has some suggestions for PPE, masks, and materials. Vanessa, do you want to jump on?
Yeah, hi. So, hi, I'm Vanessa, Principal of Bannister Advisors. We do effectively a type of private social work. Muted. Long story short, I'm also the mother of a medically compromised child, and I made him this mask over the weekend. Backstory, I'm also a trained seamstress. I did that professionally for several years. I know, right? All the things.
Amazing.
Long story short, I developed a prototype that has, from what I understand from the materials science, an article in the New York Times, tested to be N80 or higher, between N80 and N90, with the 2-level and the tight weave, and then it includes pipe cleaners so that it has a tighter seal and ear loops. So anyway, I'm making these, and I want to figure out how to share the kind of recipe for it, because there are a lot of other quilters, for example, that could be rallied to do this. So I know that the Million Mask Challenge is really geared toward healthcare workers. So I have the prototype. It works. I have 3 different sizes.
Well, let
talk
us
more
know
about that. I'm just trying to be creative. I'd love to share that in a way that
let's do it.
Can be organized. So
that's great.
Anyway,
follow up.
I don't know, maybe not for this call, but just for later, we should talk more.
Sounds good. Sounds great. We can send that out through our WASHA follow-up. So I do want to get to a couple of the other questions that have come along in the meantime. One was a specific question about who should be giving blood, or should there be certain populations who should not be giving blood? So age cutoff, any underlying issues like hypertension or chronic diseases, should those folks not be giving blood?
Well, I don't know that there's an age cutoff. There is a blood count cutoff. So people that are anemic, they're not going to take blood from. That's for your own good. And there are certain like immunocompromised people who know they are that would not normally be donating blood. But unless they will ask you if you've had recent cough or illness or known COVID positive, but if you've been symptomatic in X period of time, and actually after you give blood, they ask you to report if you become symptomatic. So because they cannot use that blood if that's the case. So I would contact them if you think that you're relatively healthy and you're interested in donating. And there are some automatic restrictions on the different websites, but they will run through all those questions with you as an individual, and you'll know right away whether to make an appointment or not.
Right. And BloodWorks is obviously one of the obvious places here in our area. Greg Berkman is reminding me, so thanks for that, Greg.
And if you're in a part of the state, it might be the American Red Cross, whoever's your blood bank.
Yeah. We also have, Margaret Monsoroff asks, are they testing donations for COVID-19? That's a really interesting question. I don't know.
Don't know that. I don't know that.
Okay.
Yeah.
Oh, Shawn D'Amelio said that she just sent an email about that. So I'll take a look at that in a moment. In the meantime, there was another question for you, Dale.
Actually,
what is that?
I was going to say, you might want some of the blood from someone that had it a month ago,
Yeah.
because they'd have antibodies.
Yeah. Okay. So anyway, I'm getting distracted here, but one of the other questions was what's happening with OBGYN? So people are still having babies, they're in the hospital. What's happening in hospitals
Right.
outside of COVID?
Well, we're all very much aware of COVID. We have pretty much taken away any elective procedures. In obstetrics, there aren't very many things that are purely elective because babies will come when they will come. And some moms have high-risk pregnancies and need to be delivered on purpose at a certain time. So a lot of precautions. We have not been able to screen absolutely everybody before they walk in the door. That is our ideal. And that is probably where Albert's frustration will be, in that I would hope, no offense, Albert, but I would hope that we can do that, because we do have areas that are set aside, or rooms that are set aside for suspicious, which is a person under investigation. So if you have symptoms that are at all consistent with a COVID infection, we would do a screening test on those folks. And because we haven't had the rapid available, those turnaround times have been anywhere from 6 or 8 hours to several days. So our speed of getting results back is better. We are recommending separation of the newborn from the mom in someone who is a person under investigation or known COVID positive. Mother can decide against that and keep the baby in with them. If they do that, we have plans and set up for social distancing of the baby, so that there's a bassinet that's 6 feet or more away. We are really encouraging breast milk for those who want to breastfeed. So we are assisting with pumping and getting the baby that breast milk if they're not someone who can breastfeed directly. There's been a big undermining of concern, realistic, but maybe blown up a little bit beyond what we should have from both the bedside caregivers, the nurses, and the other people that work in the hospital, as well as the providers, about this 20 to 25% of people being asymptomatic, and how do we know when someone walks in the door whether they have it or not. And so because it's the absolutely only thing that happens in the hospital right now, really, that has a healthy person or healthy looking person who gets admitted, it's really important for us to be able to separate those women who have the disease from those who really don't, and protect them as well as protecting our staff. So that's the goal of where we're going. When we're gonna get there, I don't know. My personal goal is to get us at least screening people with the available screening as soon as possible, who are coming in for, say, a scheduled cesarean section or an induction, because we have a date for that and we know ahead of time, and we could potentially get them tested the day before. And I think you will see each hospital's a little bit different in their approach, and a lot of it depends on how easily they can get the testing done and how quickly it turns around.
Yeah,
So,
it seems like different hospitals it's different depending.
right.
Depending.
It totally is on all
So,
of that.
and it does lead to another question related that came up, which is for people who are like with cancer or other surgeries that are not like immediately life-threatening, but really pretty urgent.
Right.
How is that being managed, and what can you say about that?
Yeah, those are definitely happening. And I think I said on our community call last week, if you have a chronic disease and you're not getting access to your provider that you should have, speak up and make sure that you reach out. Some people have just assumed that because things are shut down, they shouldn't go in, and that's not necessarily the case. So in the Swedish system, we actually have a committee who is looking at those cases and prioritizing who needs to come in first. We've never totally shut those down anyway, because those are, so you may have, the guidelines we're using, I guess is the best way to do it, is that if there's a condition that needs to be taken care of surgically, and there would be significant impact to the patient's life or quality of life, their care, not quality of life only, that would impact their long-term ability to function, that those people could still be done. They're sort of, indicated, but not emergent. And so those are the ones we are prioritizing based on need. And so that cancer person that needs a procedure, gets it in a few weeks or a month instead of, having to wait until this is all set.
So, but what patients should be doing is contacting their doctor and having those conversations. Right now, people have bandwidth to have those conversations from the provider side. That's a question.
Exactly.
Okay.
Exactly.
Yeah. So
exactly right.
yeah. So don't assume that everything has stopped. So somebody actually just wrote in, my father's scheduled for June, stage 2 colon cancer. He's 87 and other health conditions. He's stable. But so I guess it just depends on the circumstances and how urgent and that kind of thing. So
at that age and with other, comorbidities, which many people have at that age, it's really tough to say when's the right time. I would just keep in touch with his oncology providers, and then as things open up, because now, if we really have had our peak use of our ventilators and our ICU beds and things like that, we will be able to accommodate. So part of why we stopped doing elective cases in the first place, we started with people that had a high risk of being admitted afterwards. We did not want those people exposed in the hospital. We also did not want those people using a ventilator or an ICU bed if we had a sick person coming in and not having enough. So I think as that availability gets better, some of that will open up and things will happen a little bit sooner. It's just not going to happen as fast as, what we would have been used to in the past.
Well, and I saw this morning in the newspaper, so I don't know if this is true or not, but that Washington is sending some of our ventilators to other states that will, because it looks like we can share.
Yes. We can share, and we actually, or I think I mentioned this before, we ordered ventilators, the Swedish system for sure, and Providence, so there are scattered Providence hospitals around the state, and we ordered ventilators early because we were concerned about that. And it's not like we have a surplus, but anything new coming in, the government, finally we got some government supplies, and we are having them go to places like New York, where it's really, they're really, if anybody's in crisis mode, it's them. We never got to crisis mode, which is really fabulous, because what people can expect when they come into the hospital for any reason is it may be a teeny bit slower or, a little different than a prior exposure, but you should still be getting the same quality, the same community standard of care.
Yeah. So we did have a question come in about, are there not isolated locations that are being reserved for non-COVID cases? Like for surgery or different things?
They're not for elective surgeries. There are areas that are set up for people to get the care they need based on the type of illness they have. The whole of the National Guard setup at CenturyLink Field is for non-COVID patients to be getting care, and I don't know how active that is yet. So yes, there are places where people can get that care, but right now it's indicated care, it's not elective care.
Yeah, I gotcha. So as we are wrapping up, there's a question about whether CT scans and lab work can be done at these non-COVID places, but I don't know if you can comment on that or not.
I can't. I don't really know. Yeah.
Okay. Yeah. So as we're wrapping up, I'd love to get a few more words from Albert in terms of what the assisted living communities will be facing kind of in the very near term and what it's going to take to kind of get on when we're on the other side, what might that look like? And I would like Dale to also answer that after Albert. Albert?
Right, thanks. What we do anticipate, listening from experts across the globe, literally, is that COVID is here to stay for a little bit longer than we would like to. We don't know at what level and at what rate, but even if things calm down the rest of the year, we are anticipating, at least in the retirement industry, assisted living communities, we anticipate dealing with COVID-related issues back in the flu season, although, it's not a season, but around the same time, we do anticipate that will be to some level. I don't know, again, to what, nobody knows to what degree. And so we're working on preserving some of these practices that we've developed and then repackaging them and getting our staff ready for the next round if this comes back, because this, in general, that's what we anticipate will happen.
Mm-hmm.
Yeah, I don't know whether everything else will change, because I will tell you that I don't know about other communities, but in my 8 locations, we're having plexiglass being put at the front desk, because those folks are screening people, and although we are using thermometers that are touch-free, it's still they're coming too close, in less than 6 feet.
Yeah.
In compliance with the governor's order. So now we're putting glass, right? So I don't know if those things will go away yet. So it'll be interesting.
Mm-hmm. And Dale, can you jump on and say, how will we get to the other side?
We will get to the other side slowly. One thing I can tell you that's sort of solid, I think, is that we're going to need at least 14 days of no new cases before anybody should back off. And I'm not saying the public should back off, but in terms of us starting to open up, whether it's to more elective procedures or to any of those kinds of things, we really want some stability. There are different experts around the country that are starting to write up their recommendations.
Did we lose her?
I don't know. Dale, we lost your video. Well, I'm not sure. She was calling us from her car because her home there was too much noise. So maybe she'll pop on here again. But I would just like to say that it was been really, really fantastic to have you participate, Albert and Dale, and talk with us. Does Dale feel? So I don't think that Dale said that we, the public, would be able to start back after 14 days. I think what she said was from the healthcare provider perspective, before they will open up what they are doing, they want to see no new cases for 14 days. So that's just a clarification. So we are at time. I'd like to thank everybody for participating today. We will make this recording available to our community for free. And we also wanted to let you know that a week from today, next Monday, the 13th, we'll be hosting another Washoe Community Conversation about addressing loss. And so not just death, but also loss. And we will be featuring, many of you know, Trudy James, who is a chaplain and has also done the movie Speaking of Dying, but she'll be joining us for another community conversation. So thanks so much. Hope to see many of you next week. Thank you so much, Albert. Thank you, Dale, and be in touch soon.
Thank you. Thanks.